Okay, hello. So we are here for today's reading of USMLE first aid. You are not going to miss reading. You have to read it daily consistently. Abdominal aorta and branches. Arteries supplying GI structures are single and branches anteriorly. Arteries supplying non-GI structures are arteries supplying GI structures are single and branch anteriorly. Arteries supplying non-GI structures are paired and branch laterally and posteriorly. Two areas of colon have dual blood supply from distal arterial branches, watershed areas susceptible in colonic ischemia, splenic fracture, SMA and IMA, rectosigmoid junction, IMA branches, last sigmoid anterior branch and superior rectal artery. Nutcracker syndrome, compression of left renal vein between superior mesenteric artery and aorta may cause abdominal flank pain, gross hematuria from rupture of thin-walled renal varicose, left-sided varicocele. Superior mesenteric artery syndrome, characterized by intermediate intestinal obstruction symptom, primary postprandial pain when SMA and aorta compresses transverse third portion of duodenum, typically occurs in condition associated with diminished mesenteric fat, rapid weight loss, low body weight, malnutrition, gastric bypass surgery. Okay. So this is abdominal aorta. This is superior mesenteric artery. This is splenic fracture, superior and inferior mesenteric artery, watershed. This is inferior mesenteric artery, inferior mesenteric and hypogastric artery, watershed. Rectosigmoid junction, hypogastric artery, internal iliac artery. Duodenum, aorta, superior mesenteric artery. Okay. Gastrointestinal blood supply and innervation. Embryonic gut region. Artery, parasympathetic innervation. Vertebral level, structured supplied, foregut, midgut, hindgut. Artery, celiac, SMA, IMA. Parasympathetic innervation, vagus and pelvis. Pelvic, vertebral level, T12, L1, L1, L3. Structure supplied, foregut, pharynx, vagus nerve only, lower esophagus, celiac artery only, proximal, duodenum, liver, gallbladder, pancreas, spleen, mesoderm. Midgut, distal duodenum to proximal 2/3 of transverse colon. Hindgut, IMA, pelvic, L3, distal 1/3 of transverse colon, upper portion of Symptomatic innervation arises from abdominal prevertebral ganglia, celiac, superior mesenteric and inferior mesenteric. Celiac trunk, branches of celiac trunk, common hepatic, splenic and left gastric. These constitute the main blood supply of the foregut. Strong anastomosis exists between left and right gastroepiploics, left and right gastrics. Abdominal aorta, celiac artery, common hepatic artery. Celiac artery, common hepatic artery. Left hepatic, right hepatic, cystic, proper hepatic, gastroduodenal, posterior superior pancreatoduodenal, anterior superior pancreatoduodenal, right gastric, right gastroepiploic, left gastric, splenic, short gastric, gastroepiploic. Okay, portosystemic anastomosis. Pathologic blood in portal hypertension flow through tips, re-establishing normal flow direction. Normal venous drainage, systemic venous system, portal venous system. Esophageal vein, azygous vein, inferior vena cava. This is one. Left gastric vein, stomach, splenic vein, hepatic vein, portosystemic shunt, portal vein, paraumbilical vein, umbilicus, epigastric vein, inferior mesenteric vein, superior rectal vein, middle rectal vein, inferior rectal vein. Site of anastomosis, clinical sign, portal systemic, esophagus, umbilicus, rectum. Clinical sign: esophagus, esophageal varices, left gastric, esophageal drains into azygous, umbilicus, caput medusae, paraumbilical, small epigastric vein branches of inferior and superior epigastric veins of anti-abdominal wall. Rectum, anorectal varices, superior rectal, middle and inferior rectal. Varices cut but caput medusae are commonly seen with portal hypertension. Treatment is a transjugular intrahepatic portosystemic shunt tips between portal vein and hepatic vein. Relieves on portal hypertension by shunting blood to systemic circulation. Bypassing the liver, tips can precipitate hepatic encephalopathy due to decreased clearance of ammonia from shunting. Okay. Pectinate line, also called as dentate line, formed where endoderm hindgut meets ectoderm. lymphatics. Now, visceral innervation, inferior hypogastric plexus. T12 to L3 arteries, superior rectal artery, branch of IMA. Veins, superior rectal vein, IMV, splenic vein, portal vein. Lymphatics drain to internal iliac lymph node. Pectate line drains to superior inguinal lymph node, inferior rectal vein, internal pudendal vein, internal iliac vein, common iliac vein, IVC. Inferior rectal artery, branch of internal pudendal artery. Somatic innervation, pudendal nerve S2 to S4. Above pectated line, internal hemorrhoids, adenocarcinoma. Internal hemorrhoids, abnormal distension of venous plexus, risk include older age, chronic constipation, receive visceral innervation, therefore not painful. Below pectinate 9, external hemorrhoids, anal fissure, and squamous cell carcinoma. External hemorrhoids receive somatic innervation, inferior rectal branch of pudendal nerve, and are therefore painful if thrombosed. Anal fissure, tear in anoderm below pectinate line. Pain while pooping, blood on toilet paper located in posterior midline because this area is poorly perfused, associated with low fiber diet and constipation. Liver tissue architecture. The functional unit of liver is made up of hexagonally arranged lobules surrounding central veins with portal triads on the edges, consisting of portal vein, hepatic artery, bile ducts as well as lymphatics. A. Apical surface of hepatocyte faces bile canaliculi. Basolateral surface faces sinusoids. Kaffer cells, specialized macrophages located in sinusoids. Clear bacteria and damaged or senescent RBCs. Hepatic stellate ITO cells in space of Gise stores vitamin A when quiescent and produce extracellular matrix when activated, responsible for hepatic fibrosis. Dual blood supply to liver portal vein approximately 80% and hepatic artery approximately 20%. Zone 1 peripheral zone affected first by viral hepatitis, best oxygenated, most resistant to circulatory compromise. Ingested toxins, that is cocaine. Zone 2 intermediate zone, yellow fever. Zone 3 pericentral centrilobular zone affected first by ischemia, least oxygenated, high concentration of cytochrome P450, most sensitive to metabolic toxins, that is ethanol, CCl4, rifampicin, acetaminophen, site of anabolic hepatitis. Central vein into hepatic vein. Zone 1, Zone 2, Zone 3. Branch of hepatic artery. branch of portal vein, bile duct, Kupffer cells, blood flow, bile flow, stellate cells, space of Thiesse. Uh, then biliary structures. Cholangiography shows filling defects in gallbladder. Blue arrow A. Common bile duct. Red arrow A. Gallstones that reach confluence of common bile and pancreatic duct at ampoule of water can block both common bile and pancreatic duct double duct sign, causing both cholangitis and hepatitis respectively. Tumors that arises in head of pancreas, usually ductal adenocarcinoma, can cause obstruction of common bile duct and large gallbladder with painless jaundice. Courvoisier sign. Liver, cystic duct, gallbladder, common hepatic duct. Accessory pancreatic duct. Main pancreatic duct, duodenum, pancreas, sphincter of Oddi, ampoule of water. Okay. Femoral region organization, lateral to medial, nerve, artery, vein, lymphatic. You go from lateral to medial to find your navel. Okay. Femoral triangle contains femoral nerve, artery, vein, venous near penis. Femoral sheath, facial tube 3 to 4 cm below inguinal ligament, contains femoral vein, artery and canal, deep inguinal lymph node but not femoral nerve. Okay. External iliac vessels, iliopsoas, anterior superior iliac spine, femoral nerve, inguinal ligament, facial aorta, saphenous opening, sartorius, adductor longus, femoral sheath, femoral triangle, lymphatics, femoral ring, femoral vein, femoral artery, internal triangle, Hasselbeck. Okay. Inguinal canal, deep internal inguinal ring, site of protrusion of indirect hernia. Inferior epigastric vessel, abdominal wall, site of protrusion of direct hernia. Medial umbilical ligament, median umbilical ligament, rectus abdominis muscle, pyramidus muscle, conjoint tendon, linea alba, superficial external inguinal ring, inguinal ligament, anterolateral abdominal wall layers, parietal peritoneum, extraparietal tissue, transversalis fascia, transversus abdominis muscle, internal oblique muscle, aponeurosis of external oblique muscle, Spermatic cord layers, external spermatic fascia, external oblique, chromatic muscles and fascia, internal spermatic fascia, transversalis fascia. Myopectinate orifice. Anterior superior iliac spine. Inguinal selvage triangle. Pubic tubercle, pubic symphysis. Anterior superior iliac spine. Inguinal canal contains female round ligament of uterus, male ductus vas deferens, ilioinguinal nerve, internal spermatic vessels, femoral nerve, external iliac vessels, femoral ring, evagination of transversalis fascia, internal deep inguinal ring. Okay. Hernias, protrusion of peritoneum through an opening, usually at a site of weakness. Content may be at risk for an incalcination, not reducible back to abdomen / pelvis. Strangulation, ischemia and necrosis. Complicated hernias can present with tenderness, erythema, fever. Spingallian hernia, also called spontaneous lateral ventral hernia or hernia of semilunar line, occurs through defect between rectus abdominis and semilunaris line. In Spingallian aponeurosis, most occur in lower abdomen due to lack of posterior rectus sheath. Presentation is variable but may include abdominal pain and palpable lump along the Spingallian fascia. Diagnosis, ultrasound and CT scan. Hernias continued. Okay. Next 7 more minutes. Diaphragmatic hernia. Abdominal structure enter the thorax. Bowel sound may be heard on chest auscultation. Most common cause. Infant's congenital defect of pleuroperitoneal membrane, left-sided herniation, right hemidiaphragm is relatively protected by liver. Adult laxity defect of phrenoesophageal membrane, hiatal hernia, herniation of stomach through esophageal hiatus, sliding hiatal hernia, gastroesophageal junction is displaced upward as gastric cardia, slides into hiatus, hourglass stomach, most common type associated with GERD. Paraesophageal hiatal hernia, gastroesophageal function is usually normal, but gastric fundus protrude into the thorax. Herniated gastric cardia, herniated gastric fundus. Indirect inguinal hernia goes through internal deep inguinal ring, external superficial inguinal ring, and into groin, enters internal inguinal ring, lateral to inferior epigastric vessels caused by failure of processus vaginalis to close can form hydrocele may be noticed in infants or discovered in childhood discovered in adulthood, much more common in males. Indirect inguinal hernia goes through internal deep ring, external superficial inguinal, and the groin enters inguinal ring lateral inferior epigastric vessels caused by failure of processus vaginalis to close can form hydrocele may be noticed in infants or discovered in adulthood, much more common in males. Follows the pathways of testicular descent covered by all three layers of spermatic fascia. Okay, this is the peritoneum, deep inguinal ring, inguinal canal, superficial inguinal ring, intestinal loop within spermatic fascia, spermatic cord, testis. Direct inguinal hernia protrudes through inguinal Hasselbeck triangle, bulges directly through parietal peritoneum, middle to the inferior epigastric vessels, but lateral to the rectus abdominis. Goes through external superficial inguinal ring only, covered by external spermatic fascia, usually occurs in older males due to acquired weakness of transversalis fascia. MDs don't lie. Medial to inferior epigastric vessels is equal to direct hernia. Lateral to inferior epigastric vessels is equal to indirect hernia. Peritoneum, intestinal loop, deep inguinal ring, superficial inguinal ring, spermatic cord, testis. Femoral hernia protrude below inguinal ligament through femoral canal below and lateral to pubic tubercle. More common in females, but overall inguinal hernias are most common, more likely to present with incarceration or strangulation versus inguinal hernia. Intestinal loop beneath inguinal ligament. Okay, 2 more minutes and new topic is gastrointestinal physiology. Gastrointestinal physiology will start tomorrow. We'll see whatever we have covered today. We are very proud of ourselves that even after a long 12-hour internship shift, we are still coming and reading, being consistent, following our routine. That's pretty good. We have covered a lot actually. Yes, we started from today. Yes, we started from here digestive. No, here it. Yes, we started from here abdominal aorta and branches, gastrointestinal blood supply and innervation, celiac trunk, portosystemic anastomosis, pectinate line, liver tissue architecture, biliary structure, femoral region, inguinal canal. Yes, we have. And myopectinate orifice hernias, diaphragmatic hernias, indirect inguinal hernia, direct inguinal hernia, femoral hernia. So we have covered this much today. I know we have not gone in depth, but it's understandable. It's okay, not bad at all. Yes. So we are very happy we did this session, and we are not breaking our streak, breaking our consistency. This is going to help us a lot. So yes, we'll see you guys in the next session.